Dear colleagues, I'm Filippo Crea, Editor-in-Chief of the European Heart Journal. Welcome to our monthly dialogue. I remind you that our dialogues are free and live streamed in YouTube. And the dialogue, I remind you, is the last Thursday of each month. It is interactive, it is free and interactive, so please ask questions and we'll give you answers. And now it is today my privilege to ask Professor Julinda Mehilli, who is Associate Editor of the European Heart Journal, to introduce the important, very important guest we have today, Roxana Mehran. I know that she's famous in the 5 continents, and I'm really grateful to Roxana for accepting my invitation and also for accepting a very interesting title she will discuss with us. And the title of the dialogue today is Women and Cardiovascular Disease, Challenges and Opportunities Discussed with a Protagonist. And Roxana is a true protagonist. And now, Julinda, please introduce Roxana for our audience, and then we will start with our questions.
Thank you, Filippo, for giving me the possibility to be here in this dialogue and to present Roxana Mehran, which is for me not only a big friend, but also a mentor, and for everybody, a well-known scientist and interventional cardiologist. Roxana, you have to excuse me because you have such a long curriculum that I need to read it. I cannot say it by heart. So Roxana Mehran, a lot of titles, is Professor of Medicine and Director of Interventional Cardiovascular Research and Clinical Trials at the Zena and Michael Weiner Cardiovascular Institute at Mount Sinai School of Medicine. She completed her training in internal medicine at the University of Connecticut, where she was also a chief medical resident before continuing her fellowship in cardiovascular disease and interventional cardiology at Mount Sinai Medical Center. Roxana Mehran is internationally recognized for her work in clinical trials with very complex data analysis and outcome research within the field of interventional cardiology. And I'm happy to say that she is not only the woman making research for women, but is the women interventional cardiologists and researchers who makes research for all people in cardiology, for all patients in cardiology, without gender differences, racial differences, or minorities. Roxana Mehran has an excellent experience and expertise in working with regulatory agencies to conduct clinical trials. Her research interest expands from mechanism of restenosis to treatment and prevention of acute kidney injuries in cardiac patients and advanced treatment for acute coronary syndrome and acute myocardial infarction, and now recently for structural heart disease. In addition to founding a highly regarded academic research organization within the Cardiovascular Research Foundation, she is also a widely published author and frequently invited speaker at national international scientific conferences such as EHJ, ACC, European Society of Cardiology, EuroPCR, or TAVI London. She has served as course co-director at the TCT for the last 30 years. She serves in many editorial boards of multiple peer-reviewed journals. She currently serves on the board of trustees of SCAI, as a member of the program committee for American Heart Association scientific sessions, as a member of the board of directors for Harboring Hearts, and as program chair for Society of Cardiac Angiography and Interventions initiative. She was the founder of SkyWin, which was the first organization for interventional cardiologists, women interventional cardiologists, which was also our example for the ERPCI women in European Society of Cardiology. She's also the Chief Scientific Officer of the Clinical Trial Center at the Cardiovascular Research Foundation. So Roxana, you have such a long curriculum, so many things, but I'm very interested to hear for you a personal question. So you were born in Tehran and grew up as a cardiologist in America, in the United States. Your wish and your dream to become medical doctor, to become a physician, started in Tehran or in United States?
It's a great question. Obviously, I have deep roots from Iran in Tehran, and I'm proud to be an Iranian American now that I've been here for over 40 years, and it's been a fantastic ride. But I would say that my zeal for medicine probably started way back when, even in Iran, where there's been incredible scholars in medicine there. And of course, I felt as one of the first members of my family to kind of go into medicine, because most of our family was mostly in either the government or in law or philosophy or poetry. It was kind of something rebellious, if you will, for a woman. And when I came to the United States, those incredible seeds sort of became part of planting those seeds in science and maths and studying those, where I felt very strong with that. And it was easier as an immigrant who didn't speak English to excel in math, because math and science have no language, right? We can learn it in any language. And so it was sort of how I excelled in high school without speaking English, being able to really do well in those subjects. So I was gravitated there. And then my brother became ill with glomerular nephritis. He was 11 and we almost lost him. And I spent many nights in the hospital with him. And that's when I knew that it was the place for me, because it was a place where you could put evidence together and use it as sort of a puzzle and solve the puzzle that then saves lives. And he's now 50 plus years old and doing extremely well with 2 children. And so it's sort of what medicine can do. And I was obviously extremely dedicated after that to make sure that I could, and maybe that's why I'm still interested in kidney injury and renal disease, because of what happened with my own brother.
Why did you select cardiology? Which triggered you this wish?
I think cardiology was sort of like a natural fit for me, because I'm as I said, I'm a problem solver, and I think in cardiology you get to the answer. I guess I'm a little bit, I would say, impatient. I like answers right away. And I think in cardiology, especially in the cath lab, and especially in treating patients with acute myocardial infarction and critically ill patients, you get the results right away. And I felt that really empowering, but as well as seeing all of the science and the research that went into cardiology. I was very lucky to be there in a very early time of PCI. So I got to see the evolution of PCI. And I think, you were there too, Julinda. You also contributed so much to the field by your research and your work. And it was obviously exciting to be there at that time. And I think we were very lucky to be able to go into this field.
What was your biggest achievement in your career?
Well, it's hard to say. I don't want to just kind of say that what are my achievements. It's the achievements in cardiology. And I think we all need to kind of feel really good about our field, especially interventional cardiology. It's such a rewarding field. And that's why I think we need to attract more women to it, because I think it's such a fantastic field. And collectively, we can do so much in improving the lives of our patients, both in quality and quantity. And I think that when you think about some of the things that we have done, like, for example, understanding the issues with very early on with in-stent restenosis, and then really pushing that this was going to be a big issue, especially if you had diffuse in-stent restenosis and the patterns of in-stent restenosis, and really pushing it out there. And now we don't see restenosis. We talked about acute kidney injury very early on with the risk score and understanding that we needed to take preventive measures. It used to be at 20%. Now it's in a few percentage, 4 or 5%, because we're taking care. When we started to see data that, yes, if you push antiplatelets and you're doing so well with your stents, maybe you're pushing the envelope too far, and that now we have to think about bleeding. And of course, now we're looking at bleeding avoidance strategies. So I think what this is a collective way of making observations, finding problems, addressing them, putting them out there, talking about the limitations of our therapeutic regimens, and then finding innovative approaches to improve the health outcomes of our patients. And I think for me, that's the most rewarding.
Did you have any difficult moment in your career?
Every day is a difficult moment in the career.
The most difficult moment at all.
Cardiology.
Do you have
Every
one?
day. I think, you know, look, I think where I started and you came, you're a lot younger than me, Julinda, so I'm not doing that. But I think, you know, we had it very tough. I mean, when I first came out, I was one of the very few, a handful of interventional cardiologists who were women. We weren't taken seriously. We worked a lot harder. I remember being pregnant and sleeping under my desk and not going home. I remember delivering my child and coming to work with the wristband still on my hand after delivering my child. I remember a lot of difficult times, and we had to be smarter, work harder. We had to just do twice as much and still not get the recognition. So yes, those are difficult moments. And you could say, well, you know what, this will never work. And now I think the tsunami, I think it was the tsunami back then for us as women. And I think now we're in a better place, but I don't think we have walked the walk yet. I think we have maybe picked up the big rocks, but there's still gravel on the ground. There's still a lot of unknown obstacles for women. And I think that sometimes if you get rocks in your shoes, you can't go very far, maybe a flat surface. But if you always have rocks in your shoes, you're never going to go as fast as someone with a beautiful, perfect, you know, path and great shoes with not even gravel. And I think a lot of women walk with rocks in their feet, in their shoes. And so therefore they have to work harder, be more resilient, continue to, you know, outsmart their colleagues, and have to work a lot harder to be recognized. It's gotten a lot better. I can't say that it's as bad as what it was before. I was lucky because I was one of the lucky few. I had Marty Leon, who really, really recognized my talent and put me on the stage. And he made sure he walked away from the stage, but he stood behind me, making sure if I fell off, he was there to push me up again. And that's what we all must do for all of our talented men and women who are working with us, our mentees. And I think he was the quintessential mentor that made me believe in myself, and also gave me the stage that was necessary, and of course, all of the important opportunities.
Roxana, thank you for your answers, but you are not only a top scientist and top cardiologist, you also devoted a lot of efforts in addressing the issue of sex and gender-based inequities in cardiovascular medicine. And you are really an example for all of us. But what triggered your interest in this specific issue?
Well, it's sort of like anything else, right? When you start to see that, of course, cardiovascular disease is the #1 cause of death of men and women. And of course, 4 decades ago, we were doing terrible for women. We had all these awareness campaigns that continued to improve and reduce the cardiovascular events in women. But then we began forgetting about that again. And there was a decline in that, there was a slowing of that decline over the last decade. But I've been watching that from the time, of course, I'm a woman and I always care about women. I noticed that one of the first times that I noticed that there was disparities of care was when I was a medical student in University of Connecticut, when I was there as rotating through in one of the very, very busy hospitals in Hartford, Connecticut. And in the emergency department there, I was rotating, and I was a medical student, and there were two patients, a man and a woman, both complaining of chest pain, both having nausea and vomiting. And my supervisor told me that I should go see the man first because he's probably having an MI and she's probably just anxious. And I went, and I, of course, believed him. And I went and I saw the man who was having a gastrointestinal upset. And the woman behind me waited another hour with her tombstone ST segment elevation myocardial infarction. I will never forget that. And that just really upset me in a way that I felt that I was doing the wrong thing, that how did I not pay attention to that? And then I realized that the implicit bias that we all facing in our workplace also is there for women. And of course, we've always thought about coronary disease and heart attacks in the elderly female population because we felt like they were protected by their estrogen. But of course, we're now seeing a rise in acute coronary syndromes, acute myocardial infarction in women less than the age of 55 years, less than the age of 45 years. And we're now finally understanding all of these different pathobiological mechanisms that you at EHJ have done a great job in putting on papers on Manoka, Anoka, SCAD, Takotsubo, microvascular dysfunction, vasospasm. No, women are not crazy. They're actually having symptoms and they're actually at risk for cardiovascular events. And so, of course, those things really sparked my interest. And then I started writing about it. And then, of course, the bleeding issues being so prominent in women in PCI. And then us not always finding a bad outcome in our female patients, and everyone saying it's because they're studded with risk. That's why. And then we start to see some real issues in under treatment, under diagnosis, under recognition of symptoms in women. And then came the commission from the Lancet, which was, I think, the icing on the cake to be able to really, really dive in deeply and answer those questions and hopefully put action plans in place instead of talking about these things.
Well, thank you for raising the important role of microvascular dysfunction, spasm in women. As you know, this is one of my interests. And also we have a question from Paolo Angelini raising this issue, the importance of microvascular dysfunction and spasm in women. But I'd like to come back to this very, very interesting initiative, the Lancet initiative, Women and Cardiovascular Disease. So you are the leader of this commission. What, I mean, is something which has already been fully developed or is work in progress? And if it is work in progress, what will be your next aim in this setting?
Well, the commission was a 4-year project, honestly. 4 years ago, the Lancet editors-in-chief asked me to lead this commission which is a global commission of understanding the global burden of cardiovascular disease in women, and in identifying what were those existing evidence and gaps in cardiovascular research, treatment, access to care, prevention for women. And we assembled 17 world experts, all women, and they always ask me, why is this all women? And my answer is, so don't ask that question, because that really makes me upset, because when we always have authors, 17, 20 male authors, no one ever asks, why are these authors all men? So we gathered the best experts, and they just happen to be women. And we'd love to have more male experts in the area of cardiovascular disease in women. But for whatever reason, the amazing experts were women, and we were very happy to have 17 women from around the globe. And then, of course, the aims is to reduce the global burden of cardiovascular disease in the next decade, and for us to promote cardiovascular health and improve the health outcomes of women by evaluating what the gaps are, igniting the awareness of sex and gender differences and disparities, and providing a springboard for future research, and really kind of coming back every year with a big progress report. We're going to be working very closely with the IHME for the Global Burden of Disease group at the University of Washington, and continuing with a live website that allows us to get real-time data into that website that gives you the opportunity to understand what those risk factors are in different parts of the globe, and what are the lowest hanging fruits, and how can we address these disparities right away to hopefully make an impact.
Thank you, Roxana. And continuing in this direction, if we want to be more analytical, we can identify three main areas in which sex and gender-based inequities can be observed. One is authorship, as you said before. The other is enrollment of women in trials, and then differences in clinical practice, the way we treat men and women. Can you share with us your views in these three settings: authorship, enrollment in trials, and clinical practice?
So let me start with the enrollment in clinical trials, because I think that's a really, really important one. For whatever reason, even though there's been legislation in the United States passed in the 1980s and 90s that mandate inclusion of women, women are still underrepresented in majority of cardiovascular clinical trials. Now, why is that? Probably because we put these very tight inclusion and exclusion criteria that then excludes women. So that's one of them. And the second one is that we don't really work hard to find ways to bring the information of the clinical trials to women. Now, if you remember, when you see a patient, usually, and if you want to bring them into a clinical trial, if you ask the guy, he says, well, I have to see what my wife says. I got to make sure she agrees that I should be on this. And women are always the ones who are making decisions for the health of the family. Unfortunately, they put themselves last, and they're usually not even asked to participate. We also have an issue that even though we are underrepresented in clinical trials, women are, whenever we have clinical trials, the sex-specific data are underreported. And we don't report them. And I think one of the things that journals could do is say, we can't look at this unless you at least put in the appendix or something the sex-specific data. We need to see those. We need to understand that this is also relevant for women. And all of this limits our potential to develop innovative approaches. And when you see a slowing of the decline of morbidity, mortality in women, and an increase in acute myocardial infarction, it's because we don't know what to do for microvascular dysfunction. We don't know what to do for MINOCA and ANOCA because we never diagnosed it in the past, and we never thought about the therapeutic regimens around it. So we need to really, really work on this. And we, in the commission, we put out a very good way, some advice. Be more inclusive, make sure that trial participation or the trials are well communicated to the clinicians who are taking care of women who might be having patients who fit into the clinical trials, not just cardiologists. Remember, women often don't go to cardiologists. They're cared for by general practitioners, OBGYN. Sometimes, they just don't go to cardiologists because they're underseen there. And then, of course, removing the inclusion and exclusion criteria, and then going to places where women are frequented. This might be, you know, the example is the barbershop for Black males, right? You went there and were able to figure out hypertension treatment for Black males in the United States. And for women, it may be churches, or where there for young women where there is child care, or whatever it is, in different places that we have to figure out where they are and go there. And then, of course, continuing this educational campaign. In terms of authorship, I think our editors-in-chief can do a better job in making sure that reviewers are, number one. One of the things that happens is that when women send their paper, and this happens in basic science, there's a lot of research on this, and I know a lot about it because we've been writing about it, is that the reviewers are tougher on women, and they give you such a huge review process that it just, like, you look at that when it comes back, reviewer 2, you know, that reviewer 2, everybody knows reviewer number 2, and you just look at that and you go, I can't do this. I'll never be able to get this done. Forget it. They just never go through it. So I have asked that reviewers remain blinded to who the authors are, especially because you could kind of figure out the gender or the sex of the first author. And then, of course, to kind of really push your agenda forward is to make sure that authors are being fair to their younger colleagues who have done a lot of the work. Often we see women do a lot of the legwork, even put the first draft of the manuscript, and never get, you know, maybe they get a middle authorship somewhere and don't get the prominent authorship position. There has to be rules and regulations that are set forth, and the journals could kind of make sure that authors are attesting to these rules, so that there isn't this issue of mentors you know, taking away the credit from the mentees who happen to be women. So authorship is very important. And then, of course, leadership. If we don't get authorship, it's very hard to get leadership. A lot of the academic leadership positions are based on the fact that how many authorship positions have you had that have been either senior or first or second author. So if you're not an author, you're going to have a hard time getting promoted. And I think women, even though they're working hard, they often have imposter syndrome. They feel like, oh my God, I can't be that good. And so therefore they're shy and they won't negotiate for their leadership position. And these gaps continue to remain, unfortunately.
What about clinical practice? You said before, 2 patients with the same symptoms, a man with myocardial infarction and a lady with anxiety. Other more general comments on this issue, different ways we treat men and women, and in which settings in particular you believe this happens?
I think we've seen it a lot. I mean, I think, for example, when a woman bleeds, we've seen this very, very interesting sex and gender disparity, that if the bleeding patient is a woman, you stop statins, you stop it in all of them, but much more often in women, statins, beta blockers. That has nothing to do with bleeding, but you just kind of stop treating them. You like, hands off, this patient, this little old lady, don't touch her because she'll bleed, or and something happens, some event happens to that woman, we stop treating them. I don't know why that is, but I see it over and over again. Referral for angiography. Often we'll find reasons not to refer patients to angiography. And, you know, honestly, I mean, I think in structural heart, and Julinda could talk about this because she's a prominent and incredible operator with structural heart disease, so much better than me. I don't perform structural heart intervention, but I think really we're seeing that the benefit is so greater of these lesser invasive treatments, yet we less often see them referred for TAVR, or even valve replacements, or left atrial appendage closure, or PFO closure, or any mitral or tricuspid valve treatments. So it's unfortunate, but I think that's just the way it is.
Roxana, I'm proud to mention that in our editorial board, we had 5 women in the previous editorial board, and now there are 25. So I think
Beautiful.
we are on the right track. And Julinda, who is smiling today with us, really is a wonderful associate editor. And women, these 25 women in the editorial board are extremely active, and really I'm grateful to all of them. Before asking Julinda to come back to you with other questions, I'm reading a message from a colleague, Sok Janket from Boston. It's about a topic which was very popular some years ago, estrogen replacement treatment. There was a wave of interest because we're thought to be protective, but then trials showed the opposite. What is now the trend in the States?
Yeah, I mean, I think, you know, I agree with our colleague in Boston that maybe some injustice for the women in the world has been done with some of these, the Women's Health Initiative. I hate to go against that, but I think at the end of the day, right now at the moment, hormone replacement therapy is not there for protection of a patient for cardiovascular morbidity, mortality. Yet, I think one of the things that we have to do is to understand that in certain women, it's absolutely fine to use them, especially for symptom control. The other very important, I think we also point this out in our commission, is that the #1 risk factor, if we were to make the biggest impact on reducing cardiovascular morbidity and mortality in women, it would be identification and treatment of hypertension. So I can just tell you that hypertension is one of the most important areas that we absolutely must pay attention to. Women are not diagnosed with hypertension. Just today, before here, I saw 3 women in my office, all with undiagnosed hypertension. I was the first person who has basically diagnosed hypertension. And they've been to endocrinologists and several other places, and they said, well, they never took my blood pressure, or they never told me I had high blood pressure. And they told me, oh, it's because you're in my office, you don't have high blood pressure. And so, you know, there is a very, very important initiative that needs to happen as our diets and exercise have gotten worse, especially with the pandemic. Hypertension is truly an epidemic right now around the world. And so we need to kind of get our arms around that and take care of that.
Thank you, Roxana. I invite our colleagues sending us questions, because Roxana will address your questions if we receive them. And now, Julinda, I'm sure we have many more questions for Roxana. It's a very good opportunity today to have Roxana with us for such a long time. Thank you, Roxana, again. Julinda, please.
So, Roxana, I know that you have done a lot, not only for investigating gender and sex-related differences in cardiovascular patients, but also investigating the reasons for women being, let's say, not very supported in a leadership position. Also investigating these sex and gender-based differences in leadership. So my question to you is, first, everybody knows this, there is a gender-related difference in leaderships in cardiovascular medicine and in medicine everywhere. And what do you think, what are the reasons that therefore, and how can we change this picture?
Well, thank you, Julinda. You know, I've been talking a lot about this, and I think one of the things that we're very lucky at the moment that our societies, European Society of Cardiology, American College of Cardiology, I sit on the board of trustees of the American College of Cardiology at the moment, as well as the American Heart Association. They're all completely committed in the equal representation, certainly at the scientific meetings, which will help promote leadership and recognition of women in leadership positions by having these important roles in the scientific sessions, so that we will never again see a panel in any of these meetings that are completely male or with no exercise whatsoever of looking for the female expert for that specific topic. And all of that is changing. But I think it needs more than just that kind of an initiative. I think it needs to be, and I think that all of this was sparked by the Time's Up movement that happened in Hollywood, really, honestly. I will say that we've been talking about this for years and years. And I think that when the microaggressions and some of the harassments that also included sexual harassments were brought to fruition, that brought women down and made them feel less than what they were in terms of their knowledge and their ability. I think that became a very, very important springboard for so many other initiatives, especially in medicine. And we've seen that tide has really been very, very helpful for this next generation of amazing women who are finding a home in cardiovascular specialties. And I think this is just wonderful. But as you know, I've been very committed to this cause because I feel like, you know, in life, if you don't give back, like if I'm not going to speak up about this, who's going to? We need to, all of us need to put up this flag and say, we will not stand for injustice at all. And that we have to be recognized for quality and for the work that we're putting forth, and not about our sex, gender, color, or whatever else we bring to the table. That's a perception and the implicit bias that we all have. We're all biased, and we all must take implicit bias training on a regular basis, not just once, but on a regular basis, to keep our brains to rewire itself into the correct path, to the correct highways, rather than the highways that have been placed there since we were born. And so as a result, I founded Women as One, which is a not-for-profit organization completely devoted to this cause of promoting talented women and giving them the opportunities for escalation, for climbing, for leadership, and for recognition. And I think it's been a really, really great, fantastic movement. And we thank everyone who's been tremendous. I see many on this who are here today. I noticed some of our Escalator Award winners on this. Every dollar that comes to Women as One goes back to women, talented women. And boy, our talent directory has grown over 1,500 women. So if you are looking for any woman who you go, oh, well, we don't know any women who are experts in hypertension. Well, I got them. Just please send me a note. I'll send you 20 women, 30 women, hundreds of women who know, who are experts in those fields. And we're doing a lot of work on that. And I'm really proud of that because the program has grown, and we're hoping one day, who does this, that the mission of my organization is to remove the word women out of the Women as One, because it really should be as one. It should be an organization that's called As One. All of us working towards equality and fair treatment. And of course, everyone, not just because you're a woman should you get elevated, but because of the talent you bring to the table and the opportunities that need to be given to these talented women so that they can shine, to be key opinion leaders, to be principal investigators, to be leading clinical trials. There is no reason why every single sponsor, large pharma and device companies never use women as their principal investigators. And what they do when they choose us, they make sure they pair us with another man. And I think those things need to go away. We need to stand on our own feet and our own talent and be able to lead these important trials or initiatives or whatever it is. And that's really sort of, I believe, what's important to get done before I leave this earth.
So, Roxana, these are very wonderful words and wonderful actions that you have done. Now, my question is, in the industry, you have the female quote, you know, and they assure that they have bigger participation of women in the leading position. Do you think will be this the way for the medicine to go on for promoting women in leadership positions?
Yeah, I believe that there are many pathways that we can promote women in leadership positions. We need to give them opportunities and allow them to follow their passion, not to be disenchanted with a field that's unfriendly to a woman who wants to have a family, or to a woman who doesn't want to have a family. It's nobody's business what we want to do as women. And why is it that in job interviews, fellows are being asked, are you planning to be pregnant in the next year? It's nobody's business. And these are the kinds of private and uncomfortable situations that women are facing every day. Every day I have an email. Every day I have a story. If I were to put up those stories on Twitter, you would all be amazed. I'd get a lot more followers, but we don't want to do that. We don't want to shame people. What we want to do is educate everyone, because I believe wholeheartedly that a lot of what goes on with the microaggressions and the male dominance is actually because they just don't realize it. We just need to educate them. And I think if they knew, they would be horrified that these kinds of things are happening. And that when you ask a question that's so private about a woman's plans for pregnancy, it's just not acceptable and should never happen, but it happens. It happens every day. And so we just need to continue educating our wonderful male colleagues. I could tell you one thing, most of my mentors, because I have 100 mentors, by the way, and I tell this to all the women, mentorship is not a one-off thing. Oh, I have one mentor who's going to take me through. That's too much of a big responsibility. There are great people who could mentor you in all different kinds of parts of life. And most of my mentors and those who have given me opportunities are men, because they're the ones in the powerful positions. So it's really important to understand the importance of these amazing men who are out there, who are great mentors. I certainly were very, very lucky to have them. You know, Valentine Fuster, Marty Leon, Milton Packer. I just could go on. Arnold Katz. I could just go on and on about these amazing, amazing men who have been my mentors all these years.
Thanks, Roxana.
Roxana, thank you also for the passion in your voice, which is really involving. Another questions on this issue. I've noted a recent publication you co-authored. The title is Sex Differences in Cardiovascular Research, a scientometric analysis. What are the main results of this scientometric analysis?
Yeah, I mean, you know, what we want to do is in all of these publications is to kind of just point out the biases as well as the sex-specific differences in whether it's publication bias, whether it's you know, why is it that some of these, for example, female authors, if there are female authors, they don't make it to the big journals, they make it to the lower impact factor journals and all those things. So we are really, really looking at and trying to make an important assessment that these disparities exist, and as long as if you don't talk about them, nothing will be done about this. And I don't know that we have all the solutions, Professor Crea, but we certainly, when you talk about it, I think you were also very, very surprised, right? And wow, why is this happening? I think we had dinner together and you were just, you were mortified because sometimes you're just not informed. And I think it's important for us to hear our voices and to hear our plea. And I think that's important. And I think the other thing I want to make sure that I see on there some questions that I think are great, especially about pregnancy-related complications, such an important field of cardio-obstetrics. And what we did in the past when women got preeclampsia, preterm birth, gestational diabetes, once they gave birth, they were forgotten about. And then 20 years later, they showed up with severe multivessel disease and horrible, HFpEF, of HFrEF, of all those things that we saw that is probably has an association with evaluation of these pregnancy-related complications. And that field now is growing tremendously. I think it's a great opportunity for us to make important impact and get in there. The other thing is that there are many women who are surviving their horrific cancers at a young age, lymphomas, breast cancer, but then they're dying of heart disease because we don't realize that connection of cancer and cardiovascular disease and inflammation and the cardiotoxicity of some of these drugs that these women have had to endure for treatment of their cancers, and radiation and calcification and aortic stenosis. And then lastly, I want to talk about Lp(a), another very, very important lipoprotein that may have an important role more so in women than in men. We just don't know. We have to study it. But there is this very interesting relationship with aortic stenosis, women, and Lp(a). And now there's something to be done about Lp(a), hopefully in the future coming. So much great things for us, and so much opportunity for us to intervene from the time of inception to the end of the life of a woman. There is time. It's never too late, and it's never too early to think about heart disease in women.
Well, in the meantime, Roxana, I'm reading some wonderful comments from our audience. They are very enthusiastic about the way you are discussing this important issue. I'm reading Henriette Nielsen and Bianca D'Antono, Lizzie Brewster. I mean, the beauty of the post-COVID era at this virtual meeting, which are really global meetings. So all these comments, all these enthusiastic comments are coming from the 5 continents. And this is the magic of having this virtual world. Of course, we love shaking hands. We want to come back to live meetings, but also this opportunity of virtual meeting, embracing the full world, embracing the 5 continents is something which is very exciting. So really very enthusiastic comments from our audience. But Roxana, we still have time for some few questions. One, back to science. What are the major studies in your pipeline? Can you share with us?
Yes, I'm very, very, very fortunate to be working on several clinical trials right now. First and foremost, we have a huge study on diabetic patients at the moment, 3,000 patients to be randomized between 2 stent platforms to deal with this very big issue of restenosis in diabetic patients. So we have a new stent platform by Concept Medical, where the drug is placed on the stent after it's crimped on the balloon. So both the stent and the balloon will have some drug coating. And this is a prospective randomized clinical trial, 3,000 patients. It's called Ability DM. It's mostly in Europe and Asia, and it's going up against the best in class, the Zion stent. We're running the study here with Marie-Claude Maurice over at CIRC, and we're very lucky to be at 1,500 randomized patients. I'm also extremely lucky to be part of the executive committee of the EHJ trial, which is one of the largest studies looking at the ApoA1, a synthetic ApoA1 injection after an acute coronary syndrome, with four infusions in these patients immediately after an acute coronary syndrome, and with a hope of improving the cholesterol efflux and hopefully reducing early clinical events after an acute coronary syndrome. This is a 25,000 plus patient study. We're almost at about 15,000 patients enrolled. It's a multinational, multi-center study, and it's obviously for this drug that CSL CSL Behring has put forth, and it's CSL 112 is the agent. And then I'm working with some of the great leaders on the PCSK9 inhibitor inclisiran, hopefully a very large prospective study in high-risk patients to be included over 15,000 patients or so that we will hopefully launch, and I'm working on that. The inclisiran, as you know, is a PCSK9 inhibitor that will only require a twice yearly injection. And as everyone knows, the Orion study is already going on with our colleagues at Oxford, which is an investigator-initiated working with, but this is completely with Novartis, who's working on that. And then I'm very involved in the entire program of Factor 11, which is a Factor 11 inhibitor, which is sort of a new way of hopefully reaching that sweet spot of reducing ischemic events without too much bleeding. And so that's a whole program that I'm very, very lucky to be part of the executive committee of that. And then I'm also working on the small annulus study, which will have mostly women, 90% women with aortic stenosis, going between the two stent platforms, balloon expandable valve versus the self-expanding valves, and trying to see which one of these valves could have the best durability and the best hemodynamics and the best results in the small annulus, which is mostly seen in women. So here's a way that you could enroll a lot of women. If you find a condition that is more prevalent in women, you will have mostly women. So we went after the small annulus, where we're seeing a lot of recurrence. So we want to know what's the best valve. So you basically do a randomized study in small annulus, and Julinda will tell you that that will be about 80 to 90% women. So now we will have a trial that has mostly women. So we can do these things and be creative about our trial designs to be able to enroll more women. I'm also working on several other first-in-man studies, as well as several other studies that have to do with acute kidney injury and prevention. And we will be presenting our new and improved risk score, which should be simultaneously published in a very nice journal at the American Heart Association. So we're looking forward for that, and then hopefully other important ones. And then, of course, I'm on the steering committee of a trial named SOS AMI, which is a very large prospective study of an injectable P2Y12 inhibitor that we leave up to the patient to self-inject when they're having their post-ACS recurrent myocardial infarction or recurrent ACS, which I think I'm most excited about, because I think we're moving towards pragmatic clinical trials. And then there are several other ones that I'm hoping to work with in multiple teams and across disciplines. So we'll be very, very busy for the next few years.
Well, Roxana, this is a wonderful range of studies. Of course, the European Heart Journal is interested in what you do. When I read your name among the others, I always read the paper with a lot of attention.
Thank you.
It's really quite impressive. Although I noticed that before you said first in man study. Well, you know, comes spontaneous. Should it be first in human beings or whatever?
First in human. First in human. That's a mistake.
So not,
Thank you.
That was your mistake.
First in human studies. And all about human health. Thank you for correcting me. See, I told you, we're all biased. Implicit bias training.
This is what impressed me. If you say first in man, means that really there's a lot of work to do.
No.
First in human from now.
First in human. All about first in human.
Roxana, I have from my side one last question. I always ask our guests, what are your suggestions for the future of EHJ dialogues? We always want to improve. How can we improve?
No, I think your dialogues are amazing. I just have to tell you, I was shocked to be asked to be part of this. So I want to thank you and Dr. Mehilli for having me, and just so graceful to, and so wonderful and so lovely to be part of this. And I really am not deserving of this kind of attention. And I really appreciate it. I think it's wonderful that you are bringing more women to have dialogue with, because there are amazing female leaders out there. So thank you for doing this. Thank you for shedding light on this important issue. And, you know, we can also create new highways in people's brains by having, in an unconscious way, bringing in more women to the dialogues and making sure that they are part of the conversation. And so thank you for doing that, because that's how, you know, I was part of I wrote the prologue to a book that's called Deceptively Delicious, by Jessica Seinfeld, who is a wife of Jerry Seinfeld. And she asked me to write the preface to the book. And the book is about how do you get kids to eat vegetables. It's like a cookbook that basically puts vegetables, hides it in the food, you know, and the kids get nutrition. So you too can bring a lot of women to the table and continue in helping men understand how brilliant these women in cardiology are, and can bring more and more to the table. The topics are great that you have chosen, but giving women this kind of a stage is tremendously helpful for them. So thank you for doing that. And I hope we can have more of it would be great to have a conversation with some emerging female leaders and hearing their experiences now, and hopefully understanding and shedding light to this important issue. Thank you for doing that, Professor Crea. You're a brilliant, brilliant innovator.
Thank you, Roxana. Definitely will follow your important suggestions. Julinda, any final comment from your side? Questions or comment or remark?
I have no questions. I'm very happy to have Roxana here. It was excellent.
Thank you.
And thank you for inspiring me and the whole generations coming after me.
Oh, you inspire
thank you,
me.
Roxana.
You have given me so much advice. So you say I'm your mentor. Mm-hmm. You have mentored me. I think
you are my mentor. It doesn't change.
I remember receiving the Grunzig lecture, and Julinda, right before, she gave me such good advice to go to the podium, and I think it helped me so much. Julinda, I will never forget. What you told me, and I think I bring that now every day so thank you for your mentorship and your advice.
Thank you.
Well, it is now 1 hour of conversation, but went by so quickly because it's been really very, very involving and entertaining. Well, now this concludes our dialogue, and really I wish to thank Roxana and Julinda for this wonderful opportunity. Thank you for really sharing your precious time with us, and it's been really an inspiration for our large audience in the 5 continents. I remind you.
Can I just say one thing before we leave? Because I noticed there are so many women listening. I just want to tell these women, congratulations to you. Keep working. Be strong. Don't give up. Follow your passion. You're amazing, and somebody will see it. So just keep working hard. It's the only thing. And never give up, and feel good, because cardiology is a wonderful, rewarding subspecialty. We are so lucky to be cardiologists, and you've worked so hard to get here. So don't give up now. Thank you.
Well, Roxana, let's close on this remark. I'm reading a long list of enthusiastic comments from our audience, really an impressive list. I cannot mention them all, but it is really an impressive list. I remind you that the next dialogue will be, as usual, on the last Thursday of the month, will be November 25 at 17 CET. Thank you again, Roxana and Julinda.
Bye. Thank you.